You know, usually when we think about the structural integrity of a building, we tend to just focus on the visible materials like the concrete or the steel beams, the wood.
Right, the stuff you can actually see and touch.
Exactly. And if the floor of a house starts to sag, your first assumption is always that there's a problem with the physical materials themselves, like maybe the wood rotted or the concrete cracked because of too much weight.
Yeah, you look for physical wear and tear.
But imagine just for a second if those steel beams relied on a continuous, invisible electrical signal just to maintain their physical strength. Like if you turn off that signal, the steel doesn't just relax, it literally starts to soften and shrink and lose its mass.
I mean, it sounds totally like science fiction. You really wouldn't expect, physical load-bearing architecture to depend on some wireless broadcast just to exist.
No, you wouldn't. But when you step into the world of human biology, and specifically the female pelvic floor, that is the actual reality of what is happening inside your body. So, welcome to the deep dive.
Thanks. It's an incredibly fascinating topic today.
It really is. Today, we are looking at this huge stack of sources, including clinical treatment guidelines, urology reports, and a brand new 2026 biological study from PLOS1. And we're using all of this to answer a very specific and honestly really rarely discussed question.
Yeah, it's something people just don't talk about enough.
Right. And that question is, does the removal of your ovaries affect vaginal laxity symptoms?
And, the historical context here is what makes this so important. For decades, the whole conversation around pelvic floor weakness or like a feeling of looseness in the vagina, it's been almost entirely focused on mechanical stress.
Right, like the physical materials breaking down.
Exactly. The medical community mostly looked at things like pregnancy, childbirth, heavy lifting. The assumption was pretty much just physical wear and tear.
The structural beams cracking under pressure. But our mission today is to look at that invisible signal. We're going to explore the hidden connection between ovarian hormones and the actual physical architecture of the pelvic floor.
Which is huge for anyone experiencing this.
Yeah. We want to figure out why vaginal laxity is not just a childbirth issue, how removing the ovaries changes your body basically overnight, and what the latest science says you can do to reclaim control. Okay, let's unpack this. Where do we even begin to understand this whole hormonal broadcast system?
Well, to really grasp why the physical structure changes after ovary removal, we have to start with the whole concept of surgical menopause. Because it is a completely different animal than what most people think of when they hear the word menopause.
Right.
We're talking about bilateral oophorectomy, which is the surgical removal of both ovaries, and sometimes it's performed alongside a hysterectomy to remove the uterus as well.
Wait, I want to back up just a second here, because why are we talking about surgery? I always thought menopause was just, a natural age thing. What drives someone to have their ovaries removed in the first place?
That's a great question. There are several severe medical conditions that necessitate it. Like, the sources detail cases of severe unmanageable endometriosis, where this tissue is just causing immense pain and organ dysfunction.
Oh, wow. Okay.
Yeah. And another major reason is as a risk-reducing surgery. So individuals who carry the BRCA gene mutations, they have an extremely high risk of developing ovarian or breast cancer. So removing the ovaries is literally a life-saving preventative measure.
Okay, so these are major life-altering procedures, but how does that actually differ from the menopause transition that happens to, everyone else as they get older?
The divergence is all about the timeline. Natural menopause is a really slow transition. It typically unfolds over 5 to 10 years.
Oh, wow. Okay.
Yeah, the levels of hormones like estrogen and testosterone that gradually decline. And that gives the body's tissues, the brain, the cardiovascular system, it gives them time to adjust to this shifting environment.
So natural menopause is like a battery slowly dying over years, giving you time to adapt, whereas removing the ovaries is like suddenly yanking the power cord right out of the wall.
That is the perfect analogy. You are going from full power to absolute zero in the span of a single surgical procedure.
Man, that sounds intense.
It is. And the demographic element makes it even more of a shock to the system. Surgical menopause very often happens to women under the age of 45.
Wait, really?
Yeah, they're entirely premenopausal. Their bodies are functioning on high levels of hormones one day, and then they're waking up from surgery with basically none the next. The body is just thrust into this severe deficiency without any warning period at all.
Wow. And I guess this sets the stage for those structural shifts in the pelvis, which brings us back to that invisible signal we talked about in the beginning. I'm trying to visualize this, though. How does a sudden loss of this hormonal power cord actually change The physical shape and, like, the tightness of the muscles?
Well, we have to zoom way in for this,
Yeah.
like down to the microscopic level of the muscle fibers themselves.
Yeah.
Because estrogen is widely known in pop culture strictly for its role in reproduction, right? Like getting pregnant, having
Yeah.
periods.
Right.
But biologically, it is fundamentally a structural maintenance hormone for the entire pelvic region. The pelvic floor muscles, the walls of the vagina, the urethra, the bladder, they are absolutely packed with estrogen receptors.
So they are essentially just sitting there waiting for that signal to function normally. And when you remove the ovaries, you remove the factory that produces that signal.
Exactly. Estrogen is kind of like the manager that regulates collagen synthesis. It maintains blood flow, and it keeps muscle tone intact. Without the manager, the factory workers just stop doing their jobs.
Which leads us straight into the biology. I know we have that brand new 2026 study from PLOS1 in our stack, and they looked at ovary-ectomized rats, meaning rats that had their ovaries surgically removed to see exactly what happens to the pelvic floor muscles when that estrogen signal drops to zero.
Yeah, and the findings in that paper are incredibly revealing about the hidden mechanisms of vaginal laxity. The researchers managed to identify a very specific cellular pathway that just breaks down.
Okay, lay it on me.
They observed that a sudden estrogen deficiency leads to the rapid downregulation of something called estrogen receptor alpha, or ER alpha, inside the pelvic floor muscle cells.
Okay, estrogen receptor alpha. I'm assuming that's the literal receptor on the cell waiting for the estrogen signal to arrive?
It is, but ER alpha doesn't just catch the signal, it actually acts on it. Under normal, healthy conditions, ER alpha regulates a glucose transporter called GLUT4,
Okay.
and it also regulates a trafficking protein called RAC1, which basically helps move that GLUT4 to the outer membrane of the cell so it can actually absorb glucose from the bloodstream.
Whoa, whoa, alphabet soup here. ER alpha, GLUT4, RAC1 slowdown. Let's break that down for someone who hasn't taken a biology class in a decade. What are these transporters and proteins actually doing inside my muscles?
Right, fair enough. Think of the muscle cell as a house. Glucose is the food delivery waiting outside on this street.
Okay, I'm following.
GLUT4 is the person inside the house whose job is to open the door and bring the food inside. But GLUT4 can't get to the door without RAC1, which acts like a vehicle to drive them there.
Ah, got it.
And estrogen is the boss, giving the order to make all of this happen.
Wait, so you're saying that without estrogen giving the order, the pelvic floor muscles literally lose their ability to open the door and take in glucose? Like they're essentially starving for energy.
What's fascinating here is that is the exact biological reality. It's a localized, severe energy crisis.
That is wild.
Yeah, the researchers found that without estrogen, the whole transportation system just collapses. The disruption abolishes the co-localization of GLUT4 and RAC1. So the muscle cells can't take in glucose properly, which leads directly to mitochondrial dysfunction.
And the mitochondria are the powerhouses of the cell.
Exactly. And without fuel, they simply cannot do their job.
That is mind-blowing. When someone experiences pelvic floor weakness, they might think their muscles are just tired or relaxing too much, but they are literally biologically starving.
Yeah. And the PLOS1 study noted that this energy starvation causes rapid measurable atrophy in two very different types of muscle fibers in the pelvic floor.
Okay, what kind of fibers?
You have your slow twitch muscles, which are your endurance muscles. They provide the constant day in and day out structural hammock to keep your pelvic organs elevated against gravity.
Right.
And then you have fast twitch muscles, which are the reactive ones that contract violently to close off the urethra when you cough, jump, or sneeze.
So without that estrogen-regulated glucose uptake, both the endurance hammock and the quick reaction muscles just start to shrink.
Yes. The researchers visually observed a significant reduction in the cross-sectional area of both fast and slow muscle fibers under a microscope. The actual physical bulk of the pelvic floor diminishes. The steel beams of the house are literally thinning out.
Wow. I want to translate this microscopic starvation into the real world, lived experience of the listener. How does a person actually feel this happening to them? Is there a clinical term for this loss of bulk?
Yeah, the direct physical manifestation is what the clinical guidelines define as vaginal laxity. Patients describe it as a profound feeling of looseness, a noticeable loss of tonicity in the vaginal walls, and often a pretty significant reduction in sensation during intimacy.
But looking at these urology reports, it seems like vaginal laxity rarely just happens in a vacuum. I mean, if the whole region is packed with these starving receptors, it must affect more than just the muscles, right?
How it affects everything. Vaginal laxity actually sits under a much broader, highly recognized medical umbrella. The guidelines call it genitourinary syndrome of menopause, or GSM for short.
Genitourinary syndrome of menopause. That sounds incredibly comprehensive. What else is failing when the signal drops?
Well, because this starvation effect hits multiple systems simultaneously, the vaginal lining itself thins out and loses its elasticity, which is a condition called vaginal atrophy.
Okay.
But the shift that often causes the most distress is the dramatic chemical change in the environment.
I read about the pH shift in the sources. Apparently, in a healthy estrogen-rich vagina, the cells naturally produce a sugar called glycogen. And that glycogen serves a very specific purpose. It feeds the good bacteria, the lactobacilli.
Yes. And those lactobacilli are crucial because they produce lactic acid as a byproduct.
Yeah.
That lactic acid keeps the vaginal environment highly acidic, which is exactly what you want.
Right, because acidity kills the bad stuff.
Exactly. An acidic environment is incredibly hostile to bad bacteria and pathogens. It's basically a natural defense mechanism.
But let me guess, when the ovaries are removed and the estrogen plummets, that whole ecosystem crashes.
The glycogen production halts completely. And without food, the lactobacilli starve and die off. As a result, the vaginal pH shifts from acidic to alkaline.
Yikes.
Yeah, and an alkaline environment is an absolute breeding ground for commensal bacteria like E. coli.
Which perfectly explains the terrifying cascade of secondary issues in these urology reports. Let's put this together. The pelvic floor muscles are starting and shrinking. The trampoline that holds everything up is sagging. What happens to the organs resting on that trampoline?
Well, they start to drop. This is known as pelvic organ prolapse.
Yeah.
When the anterior wall of the vagina weakens, the bladder, which sits right above it, can literally bulge down into the vaginal space.
Oh, man.
Yeah, this specific type of prolapse is called a cystocele.
The reports describe how a cystocele creates something called a reservoir effect. That sounds incredibly uncomfortable.
It alters the basic plumbing of the body.
Mhm.
Because the bladder has dropped and lost its normal anatomical angle, it literally cannot fully empty when you urinate. Imagine a kink in a hose or like a sagging water balloon. A small pool of urine always gets left behind in that sagging reservoir.
Okay, I can see where this is going. You combine a stagnant, warm pool of leftover urine with the brand new, alkaline, bacteria-friendly environment we just talked about.
You have engineered the perfect recipe for recurrent urinary tract infections. UTIs become a chronic nightmare for many patients.
That sounds awful.
It is. Add to that urinary frequency a constant feeling of urgency and stress incontinence when those starving, fast-twitch muscles fail to hold back urine during a sneeze. The structural sagging and the chemical shifts just feed into each other in this vicious cycle.
So what does this all mean? We've painted a pretty bleak picture here. The muscles are starving, the pH is flipped, the structural trampoline is sagging, and it's all due to a sudden surgical lack of hormones. If you are a patient experiencing this, how do you fix it? What are the actual options to reverse this?
Well, the treatment landscape outlined in our sources is actually robust, but it generally falls into three main categories. You have hormonal interventions, physical rehabilitation, and technological interventions.
I want to challenge the approach here, though. If the root cause is a systemic lack of hormones because the ovaries are gone, doesn't it make sense to just give the patient a hormone pill and call it a day? Why is this complicated?
Well, systemic hormone replacement therapy, like patches, gels, or pills that circulate through your whole bloodstream, is highly recommended for women who undergo surgical menopause before age 45. That is absolutely vital to protect their bones, heart, and brain from the sudden loss of estrogen.
Right.
But for the specific genitourinary symptoms like laxity and GSM, systemic HRT often isn't enough on its own. The clinical guidelines actually point to local therapy as the gold standard here.
And by local, you mean applied directly inside the vagina, bypassing the rest of the body.
Yes, exactly. Low-dose vaginal estrogen comes in creams, tablets, or rings. There's also a precursor hormone called DHEA that can be used locally. By applying it directly to the tissue, you're instantly feeding those starving receptors in the pelvic floor and vaginal walls.
So it's much more targeted.
Yeah, it bypasses the digestive system and gets right to work, restoring blood flow, kickstarting collagen production, and feeding the lactobacilli to lower the pH back to a healthy acidic level.
But the clinical guidelines emphasize that you can't just hand this out uniformly. Like, the treatment has to be highly individualized, especially depending on why the ovaries were removed in the first place, right?
That is a paramount detail for anyone navigating this. Let's look at endometriosis, for example. If a patient had their ovaries removed to starve severe endometriosis, the medical approach requires intense caution.
Why is that?
Because endometriosis is a condition where tissue, similar to the lining of the womb, grows on other organs, like the bowels or bladder, and that rogue tissue feeds on estrogen.
Oh, I see. So giving them local estrogen to fix their pelvic floor could potentially reignite the painful disease they literally just had surgery to cure.
Exactly. The guidelines discuss something called the estrogen threshold theory. This is the clinical concern that even the incredibly small localized amount of estrogen in vaginal HRT could reactivate microscopic bits of endometriosis tissue left behind after surgery.
That's a scary thought.
It is. Therefore, for these specific patients, doctors usually move away from estrogen alone and recommend combined HRT.
Meaning estrogen paired with something else to keep it in check.
Right, progesterone. By adding progesterone to the estrogen, it helps protect the tissues and keeps any residual endometriosis suppressed while still allowing the pelvic floor to heal. It's a very delicate balancing act.
It sounds like it's all about finding the exact right chemical lock and key for the individual's specific medical history. But looking at these physical therapy reports, hormones are only half the battle. Like, if estrogen is the vital nutrient the muscles need to survive, pelvic floor therapy is the actual heavy lifting workout that builds the muscle back up.
That's a great way to put it.
Yeah, you can't just eat protein, you have to actually lift weights. You need both to rebuild the foundation.
Absolutely. Pelvic floor muscle training, or PFMT, is featured incredibly prominently in the treatment guidelines. And to be clear, the sources aren't talking about doing a few casual kegels at a stoplight.
Right.
They are outlining supervised, targeted myofascial physical therapy with a trained specialist.
And the success rates in the sources genuinely surprised me. Supervised pelvic floor training can resolve or drastically improve symptoms like incontinence and laxity in up to 74% of cases.
It's remarkably effective.
But the caveat is that it has to be done consistently for at least 12 weeks.
Yeah, consistency is everything. But remember, we are dealing with muscles that have been severely weakened and starved by surgical menopause. So sometimes the brain literally forgets how to activate them.
Wait, really?
Yeah. So physical therapists often utilize neuromuscular electrical stimulation, or NMES, devices.
How does zapping the muscles help them remember?
Well, these devices send a mild, painless electrical current directly into the pelvic floor muscles, forcing them to contract involuntarily. It acts as a bridge. It basically retrains the brain and the muscle on how to communicate with each other again.
Oh, that's fascinating.
Yeah, and once that neural pathway is reestablished, the patient can take over and do the exercises manually to rebuild the muscle bulk.
Okay, so you feed the muscles with localized hormones, and you rebuild their physical bulk with targeted, electrically assisted physical therapy. That makes total logical sense. But I have to bring up the third category, the technological interventions. Because you can't scroll online without seeing aggressive marketing for vaginal rejuvenation.
Yeah, the market for energy-based devices is absolutely booming right now. This primarily includes fractional CO2 lasers and radiofrequency devices.
Right, I see those everywhere.
The underlying concept is controlled trauma. By applying focused thermal energy or microtrauma to the vaginal tissues, the body's natural defense mechanism kicks in. It rushes blood and growth factors to heal the area, stimulating new collagen and elastin production, which theoretically tightens the tissue.
Wait a minute, though. Let's go back to our biology lesson earlier. If the root cause of this laxity is a starving, fast-twitch muscle deep in the pelvic floor, how does zapping the surface tissue with a laser actually fix the atrophy?
Well, that is the exact debate happening in the medical community right now, and the sources reflect a very cautious stance on these devices when compared to traditional HRT and physical therapy.
They seem more than just cautious, honestly. The FDA has issued explicit warnings about this, haven't they?
They have. The FDA has strongly warned against deceptive marketing practices that promote these lasers for vaginal rejuvenation or treating complex sexual dysfunction, noting that these devices are not explicitly approved for those claims.
Okay, so there's a big red flag there.
Yeah. While some smaller clinical trials do show short-term improvements in surface dryness and perceived tightness, major bodies like the American Urological Association and the UK's NICE guidelines state that energy-based devices currently lack robust, long-term safety and efficacy data.
It kind of sounds like they are treating the wallpaper when the drywall is crumbling.
That's a good analogy. The medical consensus basically advises that these interventions should ideally remain in research settings or robust clinical trials for now. They might hold promise in the future, particularly for patients who absolutely cannot use any form of hormonal therapy, like certain breast cancer survivors.
Sure.
But impartial analysis shows they simply do not carry the decades of proven, peer-reviewed backing that local estrogen and physical therapy do.
And like you said, lasers are targeting the surface tissue. They are not penetrating deep enough to bulk up the starving, fast twitch and slow twitch muscles that actually hold the bladder and other organs in place. You still have to do the physical work.
Exactly.
Okay.
You cannot laser your way out of deep muscle atrophy. The foundation has to be rebuilt from the inside out.
So, bringing all these incredible sources together, the ovaries are far more than just reproductive organs. They are the hormonal engines that maintain the structural integrity of the entire pelvic floor. Removing them causes an immediate severe energy crisis at the cellular level. The muscles lose their ability to absorb glucose, they starve, and they shrink, leading to vaginal laxity, prolapse, and the cascading symptoms of GSM.
That's the core issue.
But the great news is that through targeted local hormone therapy to restore that chemical signal and supervised physical rehab to rebuild the muscle bulk, the body's foundation can actually be restored.
If we connect this to the bigger picture, vaginal laxity after surgical menopause is a highly treatable medical condition. It is deeply rooted in cellular biology and energy metabolism. It is not a personal failing, it is not all in your head, and it is certainly not an inevitable, untreatable part of aging or surgery that anyone should have to suffer through in silence.
It's just biology waiting for the right tools to fix it. Today we learned that estrogen acts as the fundamental software running the structural hardware of your pelvic floor. It really makes you wonder what other hidden hormonal software systems are quietly maintaining our physical structures right now without us ever realizing it until the signal drops.